What does it mean to die with dignity? For some people, dignity means having control over the final moments of life, choosing when suffering has become too much, choosing to say goodbye, and choosing a death that is peaceful rather than painful. But for others, dignity means something different. It means protecting people when they are the most vulnerable, even if they are suffering, and making sure death is not offered as a solution when better care, treatment, or support might still be possible. That's why the debate over medical aid and dying, or MAID, is so difficult. Medical aid is dying generally refers to a legal process where a medically eligible patient can receive life-ending medication and choose when to take it, often because they are facing unbearable suffering near the end of their life. But the controversy is not just about the death, it is about autonomy, medical authority, inequality, suffering, and what society owes to people who are vulnerable. My thesis is that the debate over medical aid and dying continues because both sides claim to protect people from harm, but they define harm and dignity differently. Supporters of MAID focus on the harm of prolonged suffering, loss of autonomy, and painful or violent death. Opponents focus on the harm of medical error, social pressure, unequal access to care, and the possibility that people who might recover may instead be allowed to die. We move on to the first side of the debate, shown by Stephen Petros in his New York Times essay, I Promised My Sister I Would Write About How She Chose to Die. Petro highlights about his sister Julie, who had advanced ovarian cancer. She had gone through multiple surgeries, chemotherapies, and clinical trials, but eventually that pain became too much, and she had chose to opt for New York's medical aid and dying law. Her stories shows why supporters of MAID see it as an issue of dignity and autonomy. She was not just choosing death so casually, she had already been dying. Her choice was about how she would have that death happen. Petra elaborates, saying that this process was nor simple nor careless. There were many safeguards. Julie had to be a mentally capable adult, a New Jersey resident, diagnosed as terminally ill by 2 doctors. She had to request the medication more than once, wait between requests, sign written forms, and be given the chance to change her mind. These matter because it shows that MAID, at least in this case, was not presented as an easy escape. It was a regulated medical option for someone near death. This is where the pro-MAID argument becomes more powerful. Supporters are not necessarily saying that death is good. They are saying that the death is already near, and forcing someone to continue their suffering is another form of harm. In Julie's case, MAID allowed her to die surrounded by family after saying goodbye instead of waiting for the cancer to take. Moving on to the next article, this is where it complicates the issue. Stephanie Nolan's New York article, Claire Brousseau Wants to Die, Will Canada Let Her, focuses on Claire Brousseau, a woman in Canada who wants access to MAID because of severe mental illness. Unlike Julie, Claire is not terminally ill. She is physically healthy and can live for decades, but she has experienced debilitating mental illness for most of her life, including chronic suicidal ideation, repeated suicide attempts, many medications, different therapies, electroconvulsive therapy, and guided psychedelics. Claire's case raises a much harder question. Should unbearable psychological suffering be treated the same as unbearable physical suffering? Claire's 2 psychiatrists show the core conflict. Dr. Gail Robinson supports Claire's access to MAID because she sees the exclusion of mental illness as discriminatory. If mental suffering is real, and if someone has tried many treatments while still finding life unbearable, then denying them access treats psychiatric suffering as less legitimate than physical suffering. But Dr. Mark Fefegrad disagrees. He does not deny Claire's pain. His concern is that mental illness can change in ways doctors cannot always predict. A new treatment, relationship, or life change might make improvement possible. So for him, the danger is that someone may choose MAID while in a state of hopelessness, even though recovery and improvement could still happen. This is the center of the controversy, autonomy versus the medical duty to do no harm. Supporters argue that patients should have the right to define their own suffering. Opponents argue that doctors and society have a responsibility to protect vulnerable people, especially when the desire to die may be shaped by illness, poverty, isolation, or a lack of care. This is why MAID is not solely just a medical issue, it is also a sociological issue. It depends on institutions like laws, hospitals, doctors, insurance, families, and social services. Perchu notes that the medication in Julie's case cost $900 and was not covered by many insurance plans. He also points out that most people who use medical aid in dying were white and college educated. So even a law based on choice can still have an unequal if only certain groups have the money, knowledge, and medical access to use it. Nolan's article raises the opposite concern. Claire recognizes that some people with mental illness may seek MAID because they lack psychiatric care, housing, disability support, or social benefits. In that case, the choice to die may be shaped by social failure. But she also points out that delaying MAID has not come with a serious plan to improve mental health care. So the debate continues because both sides are trying to prevent harm. If MAID is legal, society must ask whether people are choosing death freely or because they are not properly cared for. But if MAID is illegal, society must ask whether it's protecting people or forcing them to suffer against their will. In conclusion, Stephen Petro's essay shows how MAID can provide peace and control for someone with terminal illness. Stephanie Nolan's article shows why expanding the logic to mental illnesses raises harder questions about capacity, recovery, discrimination treatment, access, and medical ethics. The controversy continues because both sides care about suffering, but they define harm very differently. Supporters see the greater harm in forcing people to suffer. Opponents see the greater harm in creating a system where vulnerable people may be allowed, pressured, or indirectly pushed towards death when society should be offering better care. And that is how I conclude my video essay. Thank you for listening.